Hello. Now today what we're going to do is go over the heart and cardiovascular function. Now the heart has four chambers that pump and circulate blood through the pulmonary and the systemic circuits. Now there is a difference in each circuit you need to be aware of. Pulmonary circuit, the blood vessels carry blood to and from gas exchange surfaces on the lungs. Typically the pressure to propel the blood through the pulmonary circuit is lower than the systemic circuit. In the systemic circuit, we transport blood to and from the rest of the body. The heart is located near the anterior chest wall, directly behind the sternum. The base of the heart, at its superior border, is located posterior to the sternum at the level of the third costal cartilage. Now, the apex of the heart, the pointed tip of the heart, reaches the fifth intercostal space. The right atrium delivers to the right ventricle blood, okay? The left atrium will deliver blood to the left ventricle. And you will see differences between the right and the left ventricle in the sense of muscle thickness, and we'll get into that in a bit. Now, the right atrium is receiving blood from the systemic circulation, whereas the left atrium is receiving blood from the pulmonary circulation. You can see how this works out here. Notice that the heart is not perfectly even, but kind of shifts over to the left side. Here's the apex. Here would be the base area. Here you have the sternum. Here is where the third rib is, and here is the area where the fifth rib with its costal cartilage attaching back to the sternum. Now, pulmonary circuit, very simple. What you're doing is having blood vessels that deliver blood to the lungs, have gas exchange, bring it back to the heart. Okay? So basically the circuitry is going from right ventricle, pulmonary arteries, capillaries, pulmonary veins, back to the left atrium. Now, a couple of things here I bring up every once in a while. Now, keep in mind that for diagram purposes only, for educational purposes only, venous blood appears bluish when it's deoxygenated. Arterial blood appears reddish when oxygenated. But guess what? There's a reversal in the colors that you would see between pulmonary and systemic circulation. That's because the arteries are the vessels that leave the heart. The veins are vessels that bring blood back to the heart. So in the pulmonary circuit, you're sending out deoxygenated blood for gas exchange and then bringing it back via the pulmonary veins. They're going to appear red as opposed to what you see with the systemic circuit where all the veins are blue. In actuality, our blood does not turn blue like baby blue. We did mention some of the differences in slight tones of hue changes due to when you compare oxygenated versus deoxygenated blood. Okay? Systemic circuit, you're sending the blood out to via the blood vessels in the head, neck, upper limbs, as well as the descending aorta, which will send it out to the trunk and the lower limbs. Now the heart is located in the mediastinum and is enclosed by the pericardial cavity. The mediastinum is the region between the two pleural cavities. The heart sits in the anterior portion. The pericardium surrounds the heart. This is a membrane that protects the heart. It consists of a fibrous pericardium, which consists of dense network of fibers which attach to the sternum and to the diaphragm. We have also a serous pericardium. This is two-layered. This is a parietal layer, which is outside, a visceral layer, which is attached directly to the heart tissue. You will have also a space in between. This is called the pericardial cavity, and it's filled with pericardial, otherwise known as serous fluid, approximately somewhere in the range of 15 to 50 mils. The fluid acts to reduce friction between the opposing surfaces as the heart beats. Pericarditis is an inflammation of the pericardium, and due to this infection, it can cause an overproduction of fluid. This fluid will now restrict the movement of the heart, and this condition is called a cardiac tamponade. What literally doctors have to do is reduce the amount of fluid that is in that space to allow more free expansion and contraction of the heart so that you more efficiently pump blood out into the pulmonary and systemic circuits. When they pull the fluid back, they use this with a needle precisely placed so that they can remove that fluid quickly. Now, the base of the heart is the site where great vessels are attached to the heart. What I mean by great vessels, these are the aorta, superior vena cava, inferior vena cava, and the pulmonary trunk. Okay. When we take a look at this diagram and then you do a cut right about here, you will see the aortic arch, you will see the pulmonary trunk here, which bifurcates to the left pulmonary artery and the right pulmonary artery, which then will branch off into different smaller arteries and veins, etc., once it is inside of the lungs. You notice at this particular point also, what is behind the heart is the actual esophagus, the vertebrae. You will notice that part of the arch segment was removed of the aorta, but this would be leading to the aorta, the descending aorta, okay? You will note also how the heart is located between the two lungs, as well as stationed where the sternum is here. And here you have that pericardial cavity here, okay? Now, let's talk about these membranes that kind of protect the heart. If you have a cut edge of the pericardium here, this would be the parietal pericardium. This would be, of course, the fibrous, pericardial membrane. There's a fibrous attachment down at the bottom here, which will attach to actually the diaphragm, okay? The apex of the heart is here. You can see the breakdown of the parietal layer of the serous pericardium here. You have a fibrous pericardium, and then you have this areolar tissue in the mesothelium. All right. The analogy that they're using here with the wrist with a balloon is this. You have the outer wall, which responds to the parietal layer, the inner wall, which corresponds to the visceral layer of the serous pericardium. And you'll notice how this would be comparable to what would be the heart, okay? The idea is that this prevents friction from the neighboring organs here. But if you fill this with too much fluid, it begins to have a buffering or muffling effect on the actual expansion and contraction of the heart, and thereby reducing its efficiency, having a subsequent negative effect on blood flow, tissue oxygenation, etc. And here we have again, you can see the anterior mediastinum here, and you can see this up close, and you can see also the pulmonary arteries. So these would be the great veins here. This, of course, is the superior vena cava, descending down, bringing blood into the right atrium, okay? Here you have, of course, the bronchi, but we're not going to be dealing with that until we get into the lungs. But you can see also the branching here from the pulmonary trunk, left and right pulmonary artery. Now, the heart wall contains concentric layers of cardiac muscle tissue. The three tissue layers are the endocardium, which is a thin serous membrane of connective tissue and simple squamous epithelium. This makes up the internal walls of the heart chambers. The myocardium is the thickest layer. It is composed of cardiac muscle fibers separated by connective tissue containing capillaries and nerves. The epicardium is the outermost layer. It is a serous membrane of connective tissue and simple squamous epithelium. The visceral layer, that's the serous layer, consists of mesothelium and areolar tissue. In the mesothelium, it is the epithelium that basically is lining the pleura, the peritoneum, and the pericardium. Now, if you take a look, here's this fluid space that takes this up. Here is the visceral layer of the serous pericardium. Here is the parietal layer. Notice that this kind of outer layer has dense fibrous tissue as well as areolar tissue in the mesothelium. This is the parietal layer. Here on this side, you can't have as much dense tissue because you've got to allow for the free expansion and contraction of the myocardium. Okay, but this will be attached to this mesothelium and areolar tissue to the external area of the heart. We have the myocardial here. It also has in between it some connective tissues. Notice the abundance of blood vessels here. This is to provide for rapid oxygenation and removal of carbon dioxide for these very, very active heart cells, the cardiac cells. Then you look at the endocardium on this side. This would be facing into the lumen of the heart, the chambers we would call them, with blood. And then you would have in between the endothelium, and the myocardium, you have this layer of areolar tissue. The myocardium consists, as I said, of concentric layers of cardiac tissue, cardiac muscle. Now, the atrial myocardium contains muscle bundles that wrap around the atria and encircle the great vessels. The ventricular muscles, the superficial will wrap around both ventricles. The deeper muscle layers spiral around and between the ventricles toward the apex. This is extremely important in how you're able to get a lot of force to propel the blood. Now, the cardiac muscle has intercalated discs to connect cardiac muscle cells together. It is the presence of these intercalated discs that allow for synchronized contraction of all the cardiac muscle cells all at the same time. Z lines of the muscle cells are anchored at the end of the plasma membranes, and desmosomes and gap junctions, the gap junctions playing a key role in this intercalated disc synchronization of contraction. These interconnect the cardiac cells into a functional syncytium, a fused mass of cells. Here is the atrial musculature. Notice the wrapping around, back and forth and around over the muscles. But underneath here, you have this ventricular musculature, which kind of wraps around and down and into the ventricles. Notice the presence of intercalated discs. That's one of the serious or the very prominent signs that you have the slide being cardiac muscle tissue. You will notice that these are connected together so that the cells will all contract at the same basic time. Also, you will take a look and you see the cardiac muscle cell, the intercalated disc here. You have also ample amounts of mitochondria. You need mitochondria a great deal to provide the energy for the contractions. There are gap junctions, as you can see. Here, there's also the presence of Z lines that are right here, and the desmosomes in between the cells. Basically, we want to make this one massive, powerful muscle so it can do one massive muscular contraction, a heartbeat. Now, The boundaries between four chambers of the heart can be identified on its external surface. Right and left atria have thin walls, yet are highly expandable. The sulci are shallow grooves that mark the boundaries between atria and ventricles and between left and right ventricles. You want to keep in mind that connective tissue of the epicardium has substantial fat and tends to hide sulci and other structures. That's what you see when you see dissection of the heart, or you see an actual cadaver heart or something. Now, there is a structure called the Ligamentum Arteriosum. This attaches the pulmonary trunk of the pulmonary circuit to the aortic arch of the systemic circuit. The fibrous remnant, basically, this is a fibrous remnant of really a fetal connection of the aorta to the pulmonary trunk. Keep in mind this, when we're a fetus, we don't get oxygen through our lungs. We get it through the exchange between the fetal blood supply and the maternal blood supply at this interface called the placenta. So, blood does go through the lungs, through the pulmonary circuit, but not to the degree that's necessary for gas exchange, just to the degree of allowing the growth and development of the lungs. There is a bypass circuit, and where that ligamentum arteriosum is, it was formerly, we'll call it like a shunt, where blood would go from pulmonary trunk out to the aortic arch. Okay. Now, auricle, this is a structure in the atrium that is an expandable pouch. The coronary solstice, this is a deep groove and it marks the border between the atria and the ventricles and contains fat and blood vessels. Here you can see some of this. Here's the pulmonary trunk. Here's the ligamentum arteriosum. Here is the ascending aorta, and then behind it, it would be the descending, supplying blood to the lower parts of the body. We have the auricle of the left atrium, the auricle of the right atrium, the right ventricle, the left ventricle, the anterior interventricular sulcus, which you can see here. Notice that the blood vessels here are also wrapped and somewhat hidden by layers of fat. Same thing here with the coronary solstice right here. Okay? Now, moving on. We have the anterior interventricular, which is a shallow depression on the anterior surface. It marks the boundary of the left and right ventricles. On the posterior surface, though, you're going to note the coronary sinus, which carries blood collected from the myocardium by various coronary veins and conveys the blood to the right atrium. We have also the posterior interventricular sulcus, which is a shallow depression that marks the boundary between the left and right ventricles. Here we have this here. Here we have the posterior interventricular sulcus. Here we have the coronary sulcus right here. Okay. You have, of course, the inferior vena cava coming up here, superior vena cava coming up in there, and delivering blood into the right atrium. But also what will deliver blood into that right atrium is the coronary sinus, which is right here. Notice how the veins come in and contribute to the coronary sinus. Okay? And this large vein comes around and delivers to here, which will then deliver the blood into the right atrium. Here is the left atrium with the left and the right pulmonary veins. Okay? They're bringing blood back. You notice the coloring is different because they're bringing blood back that is now oxygenated, and it will eventually be sent to the systemic circulation. The heart has an extensive blood supply. We've mentioned this a bit before, but it only makes sense. Now, this is where you're going to get a good understanding of why we have to have a good oxygen supply to the heart and how that relates to heart attacks, myocardial infarctions. The coronary arteries, both left and right, originate at the base of the ascending aorta. This is the point where blood pressure is at its highest in the systemic circuit. The right coronary artery follows the coronary solstice around the heart, supplying blood to the right atrium, portions of both ventricles, and portions of the electrical conducting system of the heart, and coordinates the heartbeat. The marginal arteries off from the right coronary artery supply the surface of the right ventricle. The left coronary artery supplies blood to the left ventricle, left atrium, and the interventricular septum. Okay, here we are. So what do we have? We have the right coronary artery here, and we also have these smaller branches called marginal arteries here. Notice that the marginal arteries come down and meet up with smaller marginal arteries from the original anterior interventricular artery. They exchange blood here in what is referred to as the arterial anastomosis. So that's an anastomosis between the anterior and the posterior interventricular arteries. Notice that the blood is coming out right at the point where the pressure is the greatest, and this is an attachment at the aortic arch of the ascending aorta. The left coronary artery will travel. You will have a branch that goes circumflex, meaning going around the heart, and you will have another branch that will be the anterior interventricular artery. This is also referred to as the left anterior descending artery. Okay? Now, the circumflex artery, this is the branch of the left coronary artery that curves to the left around the coronary solstice, meets and fuses with smaller branches of the right coronary artery. The arterial anastomosis, which I've just mentioned and demonstrated, that's between anterior and posterior interventricular arteries, and it helps to maintain a fairly continuous blood flow, despite pressure fluxes in the left and the right coronary arteries. Now, when I say pressure fluxes, keep this in mind. The heart is always contracting, and therefore, as it expands, as it contracts, you're going to have some fluxing changes, sometimes rapid changes, in flow of the arteries that are attached directly to these muscles. The anterior interventricular artery, this is also referred to as the left anterior descending, runs along the surface with the anterior interventricular sulcus. The posterior interventricular artery runs toward the heart apex and supplies blood to the interventricular septum and the adjacent portions of the ventricles. Here is the posterior view. And as you can see, we have the circumflex artery traveling down over here, down via marginal artery. We also have the posterior interventricular artery traveling downward here, and this is coming from the right coronary artery, okay? When we talk about coronary veins, we have several of them. The anterior cardiac veins drain the anterior surface of the right ventricle, empty directly into the right atrium. The great cardiac vein, which begins on the anterior surface of the ventricles, drains blood from the regions supplied by the anterior interventricular artery. Then it reaches the level of the atria and curves around the left side of the heart within the coronary sulcus to empty within the coronary sinus. The coronary sinus itself is really an expanded vein that opens into the right antrum near the base of the inferior vena cava. The posterior vein of the left ventricle drains the blood area that's supplied by the circumflex artery. The middle cardiac vein is the draining area. Basically, it drains, and its area supplied by the posterior interventricular artery and drains directly into the cardiac sinus. We also have several other coronary veins to note. The small cardiac vein, which receives blood from the posterior surfaces of the right atrium and ventricles, empties into the cardiac sinus along with the middle cardiac vein. There is a concept that you need to be aware of. This is called elastic rebound. This is the recoil of the elastic wall of the aorta after the end of the ventricular contraction, resulting in pressure being maintained during the brief pause of ventricular contraction to maintain blood pressure that pushes blood into the systemic circuit as well as into the coronary arteries. Now, this action helps to maintain active blood flow in active cardiac tissues. Keep in mind that you really can't have at any time an interruption of blood supply. And the longer that you do have an interruption of blood supply, the greater the risk of cardiac cells, the myocardium cells, dying. They're real sensitive, and they don't just grow back. We'll get more into that in a bit. Here is the area of the right ventricle, right atrium, left atrium, and what you see here is the great cardiac vein coming up and then traveling across. Here we have anterior cardiac veins. This is the anterior view. Now we have the posterior view, and here we have the great cardiac vein coming around, emptying into the coronary sinus. We also have the posterior vein of the left ventricle here contributing blood, and we have also the small cardiac vein coming in here, emptying also into the coronary sinus, along with the middle cardiac vein. Okay? Now, internal valves control the direction of blood flow between the heart chambers and the great vessels. The atria is separated by an interatrial septum. The ventricles are separated by the interventricular septum. Usually the interventricular septum is much thicker than the interatrial septum. The atrioventricular valves, AV valves, are really folds of fibrous tissue. They extend into the openings between the atria and the ventricle. The valves control the flow. The flow is, by the way, only one way. It goes atria to ventricle. You never want it in the opposite way, and you never want those valves to kind of like invert themselves. Just like if you saw an umbrella, someone's holding it in the wind, and what happens, instead of it being sort of in a U shape, it flops outward to a V shape and it completely opens up. You got to refix the whole umbrella. I'll show you how and why that occurs, and why the structures are important to keep it from doing that. The semilunar valves control the flow from ventricles to the great vessels. When we look in the right atrium, we're going to notice a structure, an oval depression called the fossa ovalis. That is a remnant of the foramen ovulae, closes off after birth and permanently seals after about 3 months. If it doesn't, that's when you get sometimes babies born, they look kind of bluish or dusty blue. They're not getting proper oxygenation or full oxygenation of the blood because it's going from right atrium to left atrium, bypassing oxygenation via the lungs. And so surgeons have to go in and do a little surgery to seal off and close the flap. Now, the pectinate muscles, these are prominent muscular ridges in the walls of the atria. In the right ventricle, you will have the tricuspid valve, otherwise known as the right AV valve. It has 3 cusps, three. The cusps are free edge of the valve, and it's attached to fibrous connective tissue cords called chordae tendineae. It is the chordae tendineae connected to the conical muscular projections called papillary muscles. These will prevent the inversion of the valve flaps. The pulmonary valve, this is a pulmonary semilunar valve, controls blood flow from the ventricle to the pulmonary trunk. There is a structure called the moderator band, which provides rapid conduction path that tenses the papillary muscles before the ventricular myocardium contracts. It stops the slamming of the cusps of the mitral valve. As you can see here we have our tricuspid valve. Blood would flow in this direction. Remember the fossa ovalis? That's right here. Now, at the edges of these cusps of the valve are fibers called chordae tendineae, and down here are the papillary muscles. When you have this contraction, these will contract and they will keep the valves open, but they will also prevent the valves from fluttering back in that direction, which would allow for the ventricles to flush blood back from ventricle to atria. You don't want that. These are supposed to close. You continue to build up pressure. This causes this valve, the pulmonary valve, to pop open and blood will flow in this direction. All right? The same thing occurs on the left ventricle, the transport from left atrium to left ventricle. You have a valve here called the bicuspid valve. It also has the chordae tendineae for stabilization, and it is anchored to the papillary muscles here. They will cause the pressure to rise and prevent backflow from ventricle to atrium, and the pressure will eventually cause the popping open of the aortic valve, semilunar valve, and blood will rush in this direction. Left atrium, which I just mentioned, I'll just go over this briefly. Basically, you're receiving blood from the pulmonary circuit. The left ventricle, the wall is much thicker than the right ventricular wall. That's because now you're going to push blood throughout the rest of the systemic circuit, systemic circulation. So you have to have a higher amount of pressure generated, and that's why you have the left ventricle being so much more thicker. Now, the mitral valve, otherwise known as left AV valve or bicuspid valve, permits the flow of blood from left atria to left ventricle. To prevent backflow, you have basically the mitral valve has two cusps. The aortic valve, which is also known as the aortic semilunar valve, permits the flow of blood from left ventricle to aorta and systemic circuit. The trabeculae carnae is a series of muscular ridges on the inner surface of the right and left ventricles. You want to keep in mind that demands of blood flow from right to left ventricles are different. This is in partly due to the wall thickness, the muscle arrangement, and the shape differs from left to right. Notice here the thick wall of the left ventricle. See how we were talking about how the muscles are arranged? It's almost like there's a rolling around the left ventricle. There's a larger but less powerful rolling around here of the musculature of the right ventricle. So when everything contracts, you get a certain amount of force generated by the right ventricle, but here you get a much greater, more vigorous contraction of the left ventricle. And that's going to generate the force necessary to send the blood. Right ventricle, remember, you're sending blood through the pulmonary circuit. A lower pressure demand. That's the right ventricle. The left ventricle, that's where you need a lot more force because you're going to push that blood through the entire circulatory system that we would call the systemic circulation. Now, when the heart beats, the AV valves close before the semilunar valves open, and the semilunar valves close before the AV valves open. Basically, as I said to you before, the chordae tendineae maintain tension on the valves to prevent a backflow. Cusps open and close depending on pressure from the atrium and ventricles and between the systemic and pulmonary circuits and the ventricular wall contractions, which increase pressure in the ventricles upon muscular contraction. Regurgitation. This is a term that's in this case used for the backflow of blood from one chamber to the other. The aortic sinuses are sac-like dilations adjacent to each cusp of the aortic valve. The right and the left coronary arteries originate in the aortic sinuses. If you look down here, we are able to see where the mitral, and so this would be the left AV valve, and then we have the right AV valve here. When you see the valves for this, what they would call the semilunar valves, that's because they look like a piece of the moon. You have here, of course, the aortic and the pulmonary. Now, these structures, and you can see at the thin tips, etc., those would be connected to the chordae tendineae. If you have the loose chordae tendineae here, relaxed papillary muscle, everything is just going to get dumped in here. Left atrium into left ventricle, right atrium into right ventricle. No big deal. But as these ventricles start beginning to increase in their tension by contracting, you're going to get the papillary muscles to contract. You're going to get a closing up of these valves. They will not be allowed to flutter back inward to allow a backflow or regurgitation, but they'll seal off. The pressure will continue to build, and then eventually it is greater than the pressure outside. So these semilunar valves will pop open and blood will flow in this direction. And you can see the same thing here when we talk about oxygenated versus deoxygenated blood. Pulmonary valve opens up, you're having deoxygenated blood head out to the pulmonary circuit. Once this valve pops open, this is to the aortic valve, that's where you have oxygenated blood heading out to the systemic circuit. All right. Now the cardiac skeleton, this is a flexible connective tissue frame that consists of dense connective tissue, stabilizes and supports valves, and electrically isolates the ventricular myocardium from the atrial myocardium. The valves consist of cusps of thick connective tissue. We have a condition called valvular heart disease, VHD. It's a disease of the deterioration of the heart valve that reduces the proper blood flow. This can be congenital or result of cardiitis, an inflammation of the heart. Damage of the valves may require replacement by artificial valves, these are mechanical devices, or xenografts, meaning a transplant of a pig heart valve. A couple of pointers to keep in mind. Mechanical valves require the patient to be on anticoagulants. Pig valves are given, but have a limited lifespan. They range from 5 years to 10 years, depending on who the cardiac surgeon is. The problem is you don't give a xenograft to a person who's too young, because what you face then in 10 years or 5 is they would have to go through another transplant, which is very intense in and of itself. So when you get to a certain point, you can then affordably give a xenograft because you figure, well, the person's 70, so they may get 5 years out of it, and by then they'll be too fragile. I'm not making this up. This is some of the stuff that I've found out. Or if you have someone who's too young, you may have to just go with an artificial valve. Here is the cardiac skeleton that we were talking about here, and it's mostly connective tissue. Here is the superior views of the semilunar valves. Closed, you see how these edges kind of come together, and then open, how they blow open because the pressure greater on the other side of this valve and causes it to open up. Now, here's the really important part. You see how these are defective? There's actually some leakage occurring, etc. These are damaged aortic valves with irregularly shaped cusps. Now, some of this may be due to what is called vegetation, growth, almost like a biofilm on some of the sides of the valves due to bacterial infections. Sometimes it's a response afterwards where you have the buildup of new tissue on there, but it inhibits the proper function of the valves to completely close, to completely open, etc. That's where you get into a bioprosthetic valve, in this case using the cusp from a pig's heart, as you can see here. Now, let's talk about some disordered diseases. One of them is arterial sclerosis. This can lead to coronary artery disease. This is the formation of lipid deposits in the arterial tunica media, resulting in damage to the endothelial lining and subsequent reduction of flow or a blockage of the artery. Now, a plaque is an atherosclerotic fatty mass deposit. This is not going to be on top of the artery, it's going to be in the artery wall. What happens is that it will restrict blood flow. This can be because it results in turbulence of blood flow through the vessel, passing by this sort of disrupted mound here where the plaque actually is. Plaques can eventually, instead of just being fatty, calcify. They can also break open and ulcerate, releasing some of this mass that can lead to clots in other parts of the body. So this is where doctors began working with technology, and they developed a technique called balloon angioplasty. This is where it's a catheter procedure in which you want to enlarge the lumen, that is the space, where the plaque section is of the artery. As the balloon inflates, it pushes open the lumen by pressing the plaque against the artery walls. The advantages is that the mortality rate during surgery is about 1%, fairly low. Success rate over 90%. Now we have improved the technique so that the procedure can be performed on an outpatient basis. Here we have the plaque, as you can see here. This is the tunica media. Here's the tunica externa. Here is the tunica intima, okay? And, I stand corrected, excuse me. This is the lipid deposit, the plaque. This is the lumen of the artery. Notice how it's been greatly reduced by the presence of this plaque. Here is the tunica media, the tunica externa. A lot of the space in here would be taken up by the plaque. Here is a plaque in a vessel wall. You can see the difference. And so the flow is not simple because there's no, how can I say it, round lumen. It's really causing some disturbances. So as the blood runs through it, it will get turbulent and will have eddies and flows. And it becomes very, very difficult to have smooth flow of the blood through this area. Here is the catheter, and here is the balloon structure, and we have the arterial wall. So this is a demonstration of an actual procedure where it basically is able to push down on this arterial wall to kind of flatten out and disperse some of that plaque along the length without causing this mound or hill, which would cause turbulence of the blood as it flows past it. Coronary artery disease, CAD, is a partial or complete blockage of the coronary circulation. You want to note that reduction in coronary blood means reduction in the heart performance due to the great demand of oxygen and nutrients by the cardiac myocytes. Coronary ischemia. This is reduced blood supply due to the partial or total blockage of the coronary arteries. The blockage can be a combination of plaque and or an actual blood clot, a thrombus. This can also result in a myocardial ischemia, in other words, a heart attack. Okay? Now there is structures such as a stent, which is a fine wire mesh inserted into the vessel to hold open the lumen of the artery. Now it can be coated with drugs to prevent the continued development of the clot. It is also used to reduce the return of plaque blockage after a balloon angioplasty. This is a color-enhanced digital subtraction angiography. Here you have the major branches of left and right coronary arteries. They are clearly visible. You can see the tissue pretty much fairly active. Now look at this and then compare it to what you see here. Of the same DSA of the heart of a person with advanced coronary artery disease. If you notice here, there's very little blood supply coming down some of these branches here. And there is almost virtually dead tissue up here and dead tissue up here. And so you have a severe restriction in the ventricular myocardium. And so being severely restricted, it will not beat as well, it will not contract as well. You won't get complete and effective pushing of blood out of the heart. Here is another image which is fascinating because you have a coronary artery here, and they put in a stent which causes a widening out and a more effective blood flow here. Now, the cardiac cycle is a complete round of systole and diastole. We got to get over some terms first. A single cardiac contraction is referred to by common parlance as a heartbeat. Cardiac cycle is the period between the start of one heartbeat and the beginning of the next heartbeat. The heart rate is measured in heartbeats per minute. The cardiac cycle consists of both systole and diastole. Systole is the contraction. The chamber contracts and pushes blood into the next chamber or into the arterial trunk. Diastole is the relaxation. The chamber relaxes, the muscle will relax, and as it does, the chamber fills with blood and prepares for the next contraction. Interestingly enough, the time course of systole and diastole sequence is really about 800 milliseconds. So the way to think about this, remember, milli is a thousandths. So 800 thousandths of a second, you're really talking about 0.8 seconds for each complete systole and diastole to occur. That's why we average out 75 beats per minute. If you look at the cardiac cycle, you have periods of relaxation and contraction. If you talk about it here, once you have the relaxation, the atria contract and blood pours in, the ventricles will contract and blood is sent out via either the systemic circuit or the pulmonary circuit. And then we go back to relaxation. Now, in this cycle, you can see this cardiac cycle fairly well done up. You have the atrial systole first, but at about 100 milliseconds, the atria begin to start going through relaxation, and that's the diastole. Meanwhile, the ventricular systole takes off, and this continues until 370 milliseconds. Then you have ventricular systole. The cardiac cycle will create pressure gradients that maintain blood flow. You want to keep in mind, though, that during increased heart rates, the diastole time interval is reduced. You can check that chart in a minute. The isovolumetric contraction, what does that mean? It means you have contraction, but there's no change in the volume. Okay? When I talk about ventricular ejection, that's the ventricular pressure has surpassed the valve limits. So the valves have a limit to the pressure differences, and when the pressure exceeds that, the valves open and the blood rushes past the valves. Ventricular diastole. Early, this is when the ventricles relax and the pressure drops. The blood will flow back against the cusp, forcing the valves to close. In isovolumetric relaxation, iso is the prefix denoting equal. The ventricular relaxation occurs, but no change in volume of the blood in the chamber valve. Valve pressure is not high enough, or is not high to open any of the AV valves. Okay. Here's the main point of what I'm trying to explain. Cardiac cycle begins. Atrial systole, contraction of the atria. Blood flows into the ventricles. Then it stops because you have atrial diastole. It relaxes. The ventricular systole starts off, the first phase is isovolumetric. You're contracting, but no change in the volume occurs inside of the ventricles. When you continue with ventricular systole, the second part, you will start to have ventricular ejection. Blood will move either into the pulmonary arteries or the systemic arteries. The ventricular diastole, the early part, everything just closes. The isovolumetric relaxation, the muscles, particularly of the ventricles, continue to contract, continue to expand and relax. And so the ventricles have a change in the pressure, but nothing has changed in the sense of popping the valves open. Finally, in late ventricular diastole, the valves pop open because the pressure in the atria is greater than the pressure in the ventricles. The cardiac cycle creates pressure gradients to maintain blood flow. Review the chart that I'm going to show you in a second to connect pressures with valve sounds and systole and diastole. There's a concept that you need to be aware of. It's called the Dichroic Notch. That's when the aortic valve closes. The pressure rises again as the aorta's elastic walls begin to recoil. So what you see here is your dichroic notch. Here's the idea. Your aortic valve opens, pops open. You're going to start seeing this increase in the ventricular pressure. In part, that's because the left atrium is ejecting blood into the ventricles. So obviously there would be an increase in pressure to a point. But then the mitral valve closes. Once that closes, you will notice that the pressure here will increase in the left ventricle. As it does, you get also the aortic valve popping open, and the ventricle ejection occurs. Now, what happens here? I've already sent out the blood. The aortic valve will close, clump. But remember that the aorta are large, they are elastic, so they swell up. So as they start to stop swelling, they're going to continue to begin to recoil and causing this small hiccup of pressure in the atria. The pressure will continue to drop, then you get isovolumetric relaxation occurring, and eventually you get to the point where the pressure is low enough to cause the mitral valves to pop open and blood will flow from atria back into ventricles. Note that you also have when valves open, when they close. This accounts for the noise that you hear. Mitral valve closes, bang, that's the lub. Mitral valve opens, you get lub, and mitral valve closes, or wait a minute, it opens here, you get the dub. Now, the cardiac muscle cell contractions last longer than the skeletal muscle fiber contractions. Why? This is primarily because of the differences in calcium ion membrane permeability. I encourage you to review calcium signal, which results in a skeletal fiber twitch, and the reuptake by the sarcoplasmic reticulum. The refractory period ends before the peak tension develops. Now, with the cardiac muscle cell, the action potential is prolonged because of extracellular calcium ions enter for an extended period. This is important. Now, you might say, why? The refractory period continues until relaxation is underway. This prevents tetany. In other words, the capacity to be locked up in a complete contracted state. And if you had that tetany where everything was all locked up and tightened up for a heart muscle, you will die. Here's the comparison. Our skeletal muscle fiber and action potential, bing, coming down. The first part, the blue, is action refractory period. The orange is the relative refractory period. Here, the tension will begin to build up very quickly and eventually come to a peak and then come down. But it's different with cardiac muscle cells. Notice that you're going to have the membrane potential shoot all the way up to a plus 30 from a minus 90. And then notice that instead of going right back down, you've got this very elongated time period before it starts coming down, which accounts for why the contraction takes a little bit of time for it to be ready as a warrior. Now, cardiac action potentials. You have rapid depolarization, and you're going to have also the concept of plateau, membrane potential, and depolarization to occur. Let's talk about these. The rapid depolarization, this is due to sodium voltage-gated channels. The process provides rapid, massive influx of sodium. Remember, sodium's greater in concentration outside the cell and much less inside the cell for any cells. So this particular depolarization is called the fast sodium channels, due to it being open only a few milliseconds. The plateau membrane potential. Once you hit 0 millivolts for a long time, the depolarization lasts a longer time due to the opening of slow calcium channels as the sodium channels close. The entry of the calcium balances out the loss of the sodium ions. And then finally repolarization, which after about 175 milliseconds, calcium channels begin to close and slow potassium channels begin to open. The repolarization will occur. Now, potassium ions rush out, and this restores the resting potential. By the way, what's the pump that resets everything? The sodium-potassium pump. Yep, just like what you see in a skeletal muscle. The potassiums that were kicked outside have to be put back inside of the cell. The sodium ions that were put into the cell have to be kicked back outside of the cell. So the absolute refractory period for a cardiac muscle cell is 200 milliseconds, whereas the relative is about 50 milliseconds. So here you have the rapid depolarization. You have your stimulus, boom, up. Now all of this is the absolute refractory period. The relative refractory period here is during repolarization. Much longer time course than the 0, 1, and 2 millisecond action potential. Now, electrical events of pacemaker cells and the conducting system establish the heart rate. There is a formula that you need to know straight out and have it kind of memorized. Cardiac output is equal to heart rate times stroke volume. So the body adjusts the cardiac output so that the peripheral tissues receive an adequate circulatory supply under a variety of conditions. Basically, they adjust to maintain homeostasis despite changes to the external or internal parts of the body. Autorhythmicity. This is the concept where cardiac muscle tissue contractions occur with or without neural or hormonal stimulation. So it has its own capacity to generate some type of contraction. The conducting system for the heart is a network of specialized cardiac cells. These consist of pacemaker cells and conducting cells that initiate and distribute the stimulus to contract. Here you have a typical electrocardiograph wave. And so you have heart rate measured by each one of these peaks times stroke volume, how much each peak is churning out. So in other words, number of heartbeats times the amount of blood that's being pumped out each each time you have a heartbeat, and that's going to give you the cardiac output. As you can see in this diagram, this example, heart rate 75 beats per minute, stroke volume. Stroke volume, how much each time you have a ventricular contraction, how much blood are you sending outside of the heart? Let's say it's 80 mils per beat. When you multiply that together, you get 6,000 milliliters per minute, or 6 liters a minute. The conducting system components, these are extremely important to know. Hint, hint. And so I'm going to go over them. The sinoatrial node, SA, is embedded in the posterior wall of the right atrium. The action potentials start the process and send signal to other components. The impulse rate is in the range of 60 to 100 impulses per minute. The internodal pathways, these are conducting cells which distribute contractile stimulus to the atrial muscle cells as stimulus travels toward the ventricles. The atrioventricular node, AV node, is located at the junction of the atria and the ventricles. Also, they contain pacemaker cells, but they do not affect the heart rate. The AV rate is 40 to 60 impulses per minute. That's basically on its own. The AV bundle is located within the interventricular septum. Okay, remember that thickened wall between the two ventricles? The AV node delivers the stimulus to these cells, normally only conducting pathway between the atria and ventricles. Finally, we get into the bundle branches and Purkinje fibers. The bundle branches, the AV bundle separates to left and right. The left branch is much larger to service the larger left ventricle of muscle. That's all what it does. It just basically innervates into ventricular muscle to get it ready to go. The Purkinje fibers are large diameter conducting cells. They're the final link to the distribution network. I would encourage you to take time to review the PQRST timing of the electrocardiogram. Here is our SA node. Here is our internodal pathways. Here is the next step, AV node. Here down, going through here, is Purkinje fibers. You have the AV bundle. You've got the bundle branches that separate out. You've got these smaller pieces here, the Purkinje fibers. You have also the moderator band. Okay, so SA node, AV node, etc. Now, let me do this here. I want to make sure I cover this. If you look at a PQRST tracing, this is for an electrocardiogram, excuse me. The action potential is generated in the SA node, right there. Bingo. Atrial activation begins. So this is the little line right here. The stimulus spreads across the atrial surface within the internodal pathways to the AV node. So now you've just covered that in P. After about a 100 millisecond delay, you will have the AV node kicking in. During this delay, the atrial contraction occurs. So now you have the impulse traveling over to the AV bundle. This is known as the PR terminal, the conduction through AV node and AV bundle. Oops, sorry about that. The impulse will eventually travel down past the AV node. We'll get into the bundle branches. So it's going to travel along the interventricular septum within the AV bundle and the bundle branches to the Purkinje fibers and to the moderator band. The papillary muscles of the right ventricle, for example, will be affected, and the ventricular contraction occurs. So here they are spreading out into the walls of the heart, the interventricular septum starting, and then they start spreading outward. Now, this is going to be the Q. You're going to have T, the complete of the ventricular depolarization. Boom, boom. That's where Purkinje fibers throughout the ventricular myocardium and causes the ventricular contraction complete. Now, normal and abnormal cardiac activity can be detected in an electrocardiogram. Okay? Real easy once you get exposed to it. The ECG or EKG, electrocardiogram, this is a recording of electrical events in the heart over time. The normal image of the normal distribution of leads results in you being able to detect the wave pattern. Now, the wave pattern consists of the P wave, which represents depolarization of the atria, atrial contraction, PR interval, which extends from the start of the atrial depolarization to the start of the QRS complex, rather than to the R, because of the abnormal ECGs, the P can be difficult to determine. The QRS complex, this corresponds to depolarization of the ventricles, and ventricles begin contracting shortly after the peak of the R wave toward the deflection of the QRS complex. When you get to the QT interval, this indicates the time from the beginning of the Q wave to the end of the T wave. This indicates the time required for ventricles to undergo a single wave of depolarization and repolarization. There are those that have long QT interval symptoms, and it basically means that the heart is weaker because you will end up with not the normal time between the Q and the T interval, but an excessively longer time. Okay, so T wave represents the polarization of the ventricles. The cardiac arrhythmias, this is when you have abnormal patterns of cardiac electrical activity. Here you have a gentleman who's had certain leads put all over him. Here is when you have the normal R, basically the PQ, R, ST wave. Okay. Roughly note again, 800 milliseconds, we talked earlier. Okay, so you start off with the P, then go to the Q, R, S, and then we see the T. The difference between the QT interval as well as the PR interval. Okay. Now, abnormal patterns. I know this seems to be like beating a dead horse, but I want you to be patient with this and hang in there, because here's part of the point. By just reading a device, and nowadays it's gotten to the point where you don't have to go to a special lab, they roll in the device, stick on disposable tabs to you that will monitor the electrical activity and convert this into information. You can have a variety of abnormal heart patterns. Premature atrial contraction, PAC, occurs in healthy people. You have an atrial rhythm interrupted by a surprise, an atrial contraction. The incident increases during basically due to certain drugs, caffeine, stress, and various drugs. Paroxysmal atrial tachycardia, PAT, you have a premature atrial contraction, and the ventricles basically are trying to keep pace. That means that you're going to have an elevation in the heart rate to 100 up to 180 beats per minute. The atrial fibrillation, AF, this is where the atrial wall quivers, the ventricles remain within normal limits. The premature ventricular contraction, this is where the Purkinje cell depolarizes to the threshold and triggers premature contraction. This is the failure of the SA node. The SA node may be atopic, that is out of place. And you may actually have another completely different atopic node present that seems to knock things out of kilter and adds a certain number of contractions per minute. Ventricular tachycardia, VT, you have 4 more PVCs without intervening normal beats. They call it VTAC. It indicates serious cardiac problems. Now, ventricular fibrillation, VF, this is when you have cardiac arrest. Ventricles are basically quivering. This is where they're all out of coordination. And so they're all doing their own little thing, causing a little contraction, etc. But the overall effect is that you have no blood flowing. So here you have premature atrial contraction. You have a P, QRT, etc. But you notice also that now you're going to have more P's. You won't have as much of the T here. And so you're losing out. Atrial defibrillation, this is when you have this QSRT, but you don't have a normal heart rhythm, as you can see here. What would be here and here is a mess. Okay, premature ventricular contractions, you can see here. Here's T. And here you have the premature fitting. Then we have ventricular tachycardia, where you have literally no time to rest, right? Do we understand each other? Okay. Ventricular tachycardia, VT, all you see are basically the ventricles doing the contraction. Everything else is kind of lost out here. Ventricular fibrillation is far worse. Basically, the ventricle is doing nothing much more than uncoordinated, unsynchronized contractions. And that leads to no blood being transferred to anywhere in the body. And that's when you have to shock the heart to resynchronize everything. Now, intrinsic heart rate can be altered by autonomic activity. This is where we get into sympathetic and parasympathetic influences. Pacemaker potential. This is the gradual spontaneous depolarization. This is due to membrane drifting to the threshold. So in essence, because of the pacemaker potential and the membrane drifting, you will always have the heart beating. Now, due to membrane drifting to the threshold, you're going to get a spontaneous depolarization rate. This tends to be faster than the SA node. And really, it's the SA node that controls other pacemakers. And this is without any influence of neural or hormonal stimulus. Under parasympathetic stimulation, acetylcholine slows the rate of spontaneous depolarization by changing to reach threshold by opening chemically gated potassium channels. Under sympathetic stimulation, the norepinephrine NE binds to the beta-1 receptors, resulting in the opening of ion channels that increase the rate of depolarization and short the period of repolarization. Here you have normal resting, going up, down, etc. Here you have parasympathetic stimulation. You're way slower. Then you go up, you get going. Slow onset, slow depolarization, quick contraction, and then slow rate. Sympathetic stimulation does the opposite. You reduce the repolarization time and you increase the number of beats in the same period of time. Now, a couple of terms to get used to. Tachycardia, bradycardia. Now, the normal range of resting heart is somewhere between 60 and 100 beats per minute. But Above 100 beats, that's where you're beginning to demonstrate tachycardia, much more faster rate of heart contractions. Bradycardia is much more slower rate, and it's below 60 beats per minute. So what controls all of this? Well, we actually have two centers in the medulla oblongata, in the brainstem, that control this. In the medulla oblongata, the autonomic control for cardiac control is basically innervation of the heart via the cardiac plexus. For the cardioinhibitory center, this controls the cardioinhibitory section, which is connected with parasympathetic control. The cardioacceleratory center controls the sympathetic neurons that increase the heart rate. So you've got one to speed up, one to slow down, and this is extremely important. They're both, remember I said there was no feeling around and no different. Yeah, there's a difference here. Take a look here. Here you are in the medulla oblongata. You have the vagus nerve that's taking impulses from the cardioinhibitory center, traveling down the cranial nerve, number 10, vagus nerve, which innervates into the heart. You have a parasympathetic preganglionic fiber, and it synapses to the cardiac plexus and to the parasympathetic postganglionic fibers. Whereas you have the cardiac or cardioacceleratory center, which has a direct nerving going down, where it will innervate via from the spinal cord. You will have the sympathetic preganglionic fiber, the sympathetic ganglia, the sympathetic postganglionic fiber, and the cardiac nerve. Now, remember that formula I gave you a while back? Basically, cardiac output, CO, is equal to number of heartbeats per minute times, okay? Times basically the number of heartbeats per minute by the stroke volume. Well, stroke volume is this other concept that we've got to get down. It depends on the relationship between end diastolic volume and end systolic volume. Or another way to say it, end systolic volume. This is the volume remaining in the ventricle at the end of the ventricular systole, where it is completely contracted as much as possible. There'll still be some blood in that space in the ventricular chamber. End diastolic volume is the volume remaining in the ventricle at the end of the diastole. In other words, at the end of its relaxation, just before it's going to start contracting again. That's the maximum volume you have. So we're going to just use a single pump model. And stroke volume really tells you the volume of blood pumped per ventricular contraction. So stroke volume is basically EDV, end diastolic volume, minus ESV, end systolic volume. It's all measured in milliliters. When we talk about venous return, this is the amount of blood delivered to the right atrium by the vena cava and the coronary sinus. Now that I've given you this stroke volume, there's a couple of other things you have to keep in mind. Filling time. This is the duration of ventricular diastole. Now there's a concept called preload, which is the amount of myocardial stretching. You see, as you're filling up, the myocardial muscle will get stretched. This being cardiac muscle, it doesn't react in the same way as skeletal muscle, etc. So the greater the EDV, end diastolic volume, the greater the stroke volume. This is related to the Frank-Starling law of the heart. In other words, as I stretch out the heart muscle, it's going to respond by a greater push, a greater contraction, increasing the force and increasing that blood getting kicked out of that ventricle. The contractility, this is the amount of force produced during the contraction. at a given volume of preload. Okay? So contractility goes up if you have an increase in the preload, the myocardial stretching, etc. The afterload, this is the amount of tension the contracting ventricle must produce to force open the semilunar valves and eject the blood. Think of it this way. Here I am going to start. I'm going to fill this single chamber. First, I have ventricular diastole. I'm filling up, filling up, filling up. Then what happens is the valves here close. I have my end diastolic volume. What is the volume in this chamber here loaded up with blood, for example? Then we start the pumping, and this is where we get ventricular systole. As it contracts, you're putting pressure. You're going to increase the pressure in this chamber here, which will then lead to the popping open of the valves so that blood can flow outward. Okay? Cardiac output is regulated by adjustments in heart rate and stroke volume. Okay? Remember, cardiac output is equal to heart rate times stroke volume. Once you review the diagram in a second, we'll go over it. And then we have also the concept called atrial reflex. This involves adjustments in the heart rate in response to an increase in the venous return. So more blood coming back from the body is going to influence the heart rate. Now, there are several other factors that affect heart rate. Body temperature or exercise. Well, body temperature does increase. Exercise would cause more mobility of the blood. Okay, I can see some of these things. Autonomic nervous system and hormones. So here's where you get into a situation where you have the normal range of cardiac output during heavy exercise. Okay, you can see it somewhere here between about maybe 17.75 to 18, all the way up to 40. Okay, this is liters per minute. Now, the average resting cardiac output is about 6, maybe 7. You don't need lots of different numbers because, interestingly enough, they find that as you get more and more exercise and you become more and more like an athlete, you have a slightly lower heart rate because the muscle has built up. You get the same cardiac output with less beats per minute. And you go, what? Because your cardiac output, or I should say, your stroke volume has increased. And so the compensatory mechanism is such that you will get the same amount of blood transported out when you're resting if you've been, someone who's a marathoner or something else like that. And hence, if you get more transported out per stroke volume, you don't need as many heartbeats to fulfill the needs. And so your cardiac output's the same. The stroke volume is greater, but the heart rate will be less. Now, there are a variety of other factors that do affect stroke volume. This is just a chart that you'll see in a second. Exercise, blood volume, blood flow, venous return, autonomic nervous system, hormones, filling time, free load, contractility, afterload, EDV, ESV, stroke volume, which we've talked about, that formula, which is EDV minus ESV, and cardiac output, which is HR times SV. By the way, the blood volume, what you have to keep in mind is this. If the blood became more viscous, it puts a strain on the heart. We'll get more into this when we get into cardiovascular afterwards in the circulatory system. If the heart becomes less filled with red blood cells, therefore contains more watery. What you're going to have is a decrease of oxygenation. The brain will trigger, and this is where you get into the autonomic nervous system, the brain will trigger the heart to speed up the heart rate to compensate for the lower oxygenation from the blood. And you can see this chart. It gets very complicated, but really it's not. Just follow it one point at a time. Exercise for all of you athletes, go through there. Blood volume. Let's say you have someone who has been seriously injured, and as a result, they have a decrease in blood volume. How would this affect the venous return, the preload, the end diastolic volume, and the stroke volume? Okay, just some of the examples. So we're pretty much finished here. Sorry about that phone ringing at the last moment. Here's what I encourage you to do. Peruse the chapter review outline. That's pages 691 to 693. Complete the review questions on pages 694 to 695 and complete the review sheets that you'll find in your text on 674 as well as 690. Now the next chapter, chapter 19, gets a lot of diagrams, etc., and I want you to be very detailed about this. And we'll be covering the blood vessels and circulation. And I hope you all have a very nice day.